Thank you all so much for joining us for today's webinar, Exposures to Viruses Among Healthcare Workers. We'll be getting started in another couple of minutes. Thank you all so much for joining us today. Our webinar will be getting started in just another couple of minutes. As we wait for people to log in here, I'd love to tell you guys about some upcoming events and webinars that we have. Our next NIOSH Industrial Hygiene webinar is going to be on March 10th, and that'll be on respiratory exposures and outcomes among cannabis workers by Dr. Christopher Simpson. We also have an ergonomics webinar sponsored by our NIOSH ERC group, and that'll be next week on February 19th, and that is using anthropometry, biomechanics, and usability to inform product design with Dr. Pete Johnson. You can learn about these events and more at coeh.berkeley.edu. Thank you all so much for joining us today. On behalf of the NIOSH-supported education and research centers throughout the country, we're pleased to present the 2020 Industrial Hygiene Webinar Series, offering free monthly webinars. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Today's webinar, Exposures to Viruses Among Healthcare Workers, is brought to you by the Rocky Mountain COEH and Dr. Rachael Jones. A few housekeeping items first. You'll be muted during this presentation. If you would like to ask a question, please enter it into the online chat or Q&A. We'll save time at the end of the presentation to address all questions. This webinar is also being recorded and will be archived for viewing on COEH Northern California's YouTube channel. At this time, we're pleased to welcome our presenter, Rachael Jones, PhD in CIH. Dr. Jones is an associate professor in the Department of Family and Preventative Medicine and the Industrial Hygiene Program Director at the Rocky Mountain Center for Occupational and Environmental Health at the University of Utah. She received her graduate degree training at the University of California, Berkeley. One of Dr. Jones's primary research areas is occupational exposures to infectious diseases and the implication of these exposures for occupationally-acquired infections. Thank you so much for joining us today.
Thank you. So you'll have to excuse me if I cough a little bit. I'm just getting over the flu, but hopefully I can make it through the presentation today. So today we're going to talk about there we go. Okay, just working here. Excuse me. That's me up in the right-hand corner. And of course, immediately after I got my headshot, I got new glasses. But today's primary objectives are shown here and match what's in the advertisements for the webinar. We're going to talk about how healthcare workers are exposed, how to measure those exposures, discuss the implications of these exposures for healthcare workers' health and for personal protective equipment. And at the end of the talk, I'll cover the latest information about the novel coronavirus, which as of today was named COVID 2019. And why is this talk about viruses and not about bacteria or any of the other hazards, prion diseases, for example, that healthcare workers experience? Well, one is that we know from emerging infectious viral diseases that it's clear that healthcare workers can become infected. And we know this because of the current outbreak with coronavirus, where healthcare workers in China have become infected with the virus. We also know this from Ebola, where healthcare workers were infected. And many of our emerging infectious diseases are viruses. And so that means we need to continue to think about issues around viral exposures. We do know that there is also a burden among healthcare workers from endemic virus diseases. In some work that I did with Yulin Shah a number of years ago, we were asked to estimate how many healthcare workers in the United States got routine infectious diseases like norovirus, seasonal influenza, as well as tuberculosis and some other organisms. We've published that influenza work where we show that tens of thousands of healthcare workers annually in hospitals and emergency departments acquire seasonal influenza infections, even though they're vaccinated. Not all of these infections result in overt disease, but it is a significant burden. Viruses are something that healthcare workers remain susceptible to over time. There are limited vaccines available for viruses, and viruses can affect otherwise healthy adults. Whereas for multi-drug resistant bacterial organisms, infection predominantly occurs among people with other health conditions. Viruses can affect healthcare workers who are otherwise healthy. And it's important to remember that healthcare workers need to be protected. Not only is it the right thing to do, but healthcare workers who are ill can infect other people. And it's essential to maintain trust with the healthcare workforce in the event of epidemics and other kinds of outbreaks. This trust is helpful to manage fear so that healthcare workers will continue to work and obtain their participation and compliance with various procedures, administrative controls, and personal protective equipment that's being used in the workforce. And this was a huge issue in the context of Ebola virus, where healthcare workers had developed initial distrust with the CDC recommendations for personal protective equipment. There was great fear because of the high mortality of the disease seen in Africa, which did not necessarily manifest in developed countries, but still created a lot of fear and hysteria. And when we were interviewing hospitals, representatives from hospitals in the Chicago area, fear manifested in a number of ways, including that healthcare workers wanted excessive personal protective equipment that made it impossible for them to actually perform the work. They didn't want to participate in or be trained to be part of Ebola response teams. And ultimately, these fears were managed through educational campaigns and integration of healthcare workers in education and practice with personal protective equipment. But this is an ongoing challenge that needs to be addressed before crises occur so that healthcare workers are prepared to provide care to ill patients. So viruses have a number of routes of exposures, and this table shows how exposure routes are defined for several common viral diseases that are in healthcare facilities. I guess SARS-CoV isn't common, but it is a well-known virus in healthcare. And how the diseases is considered transmitted by CDC and the Healthcare Infection Control Practices Advisory Committee, or HICPAC. And contact transmission, droplet transmission, and airborne are the primary routes that are considered for the transmission of any infectious diseases in healthcare settings. Contact can be direct or indirect and involves the deposition of viruses onto body parts. So indirect would be the virus ends up on a surface that is then touched, or ends up on the hand of a healthcare worker that is then transferred to a place where infection can occur. I'll talk a little bit more about the distinction between droplet and airborne, but droplet is essentially when someone coughs on your face. And airborne refers to inhalation. And you'll see here that for all of these viruses, contact is considered a route of exposure that's relevant. For most of these droplet, the respiratory viruses are considered transmitted through droplet routes, and airborne sometimes. So this means that there is some epidemiologic evidence that the virus transmission that was observed could not be explained by contact or droplet. And so in the CDC HICPAC documents for isolation precautions, they talk about kind of these atypical aerosol routes for norovirus, influenza, and also for rhinovirus. Now, some things to consider here is that when you get assigned a transmission route by the CDC and HICPAC, this triggers specific types of personal protective equipment. So for example, if you have a contact transmissible disease, then the healthcare workers are supposed to wear gloves and gowns to keep their bodies clean so that when they leave the patient room, they can take off the gloves and gowns and wash their hands, and there's no more virus on their body to expose themselves or others. In droplet, they would add a mask, which may or may not have an eye shield attached to it. So again, this would be a surgical mask that's designed to protect the spray of large droplets onto the face. Whereas for airborne, we would then add a respirator, and the standard respirator that's used is an N95 filtering face piece respirator, although other respirators can be worn and are worn in healthcare settings. But a couple things when we think about these classifications is that if you read this document carefully, it's really driven by epidemiology and not really by an understanding of the mechanistic process of the exposure pathway and infection. So for example, there's a discussion of where in the body are receptors that the viruses can initiate infection at. It just talks about, well, we got these people were infected and they were close together, so it was probably contact and droplet and not airborne. But there was an outbreak that said, for example, that somebody vomited in a theater and people that were tens of meters away got infected. So maybe norovirus is an airborne disease sometimes. And so it's driven by the epidemiology. The other thing is that there's a concept that's emerged in the last 15 years that is important in healthcare setting, because there's an idea that a pathogen's transmission route is somewhat flexible. So a pathogen could be an obligate to transmit through a certain route, that is, they have to be transmitted in this way. Preferential, meaning it's predominantly in one way, but it could be something else if a circumstance arose. And again, opportunistic, where you get this rare circumstance where that is an opportunity. And in healthcare, this is important because for viral diseases, especially respiratory viral diseases, they can require patients to undergo medical treatments and therapies that create aerosols or other kinds of things that are not seen in natural transmission settings. And so there's an opportunity for the virus to be transmitted in a healthcare setting that it might not experience were it at home, right? And this was something that I wrote about in the context of Ebola with my colleague Lisa Brousseau and others as well, in the sense that when you have a patient with Ebola in a developed country, they may get, for example, respiratory support. And we know that many respiratory procedures, including mechanical ventilation, can create aerosols, which is a potential for the virus to distribute in a different way in the environment and creating a different kind of risk for healthcare workers than might be experienced in a home where the patient is ill and lying in bed and not receiving such treatment. So the droplet versus airborne has been a debate in the literature for a number of years. And there's, I think, more consensus now that we should not be focused too closely on these distinctions between droplet and airborne. So the table shows the definitions of droplet and airborne that's used by the CDC and HICPAC. So droplet, as I said, is basically when someone coughs on your face, that you're standing close to them, these large droplet impacts onto your face and your facial mucous membranes, and you actually, can feel the dampness from that. Whereas airborne, it occurs at a long distance. They use this term called droplet nuclei to describe particles that are in the respirable size range, and then the exposure route really is inhalation. But the problem is that these definitions arose prior to the 1940s, 1950s, and early 1960s. And since then, advances in technology have allowed us to have a much better understanding of how viral pathogens are emitted from the respiratory tract, and to understand coughs. And so it's very clear that coughs are polydispersed aerosols. They undergo very rapid evaporation, but the size range of evaporated particles in a cough are still things that can be inspired or inhaled. And so there isn't really this clear distinction with regard to particle size or distance. And the distance that particles will transport from a cough through the environment is multifactorial and has to do with the angle at which the cough is emitted and the force, but also with ventilation in the room. And so that is actually very hard to predict. So Lisa Brousseau and I proposed aerosol transmission as a concept to describe this. This concept had been described before in some CDC working groups around influenza. Others have called it short-range airborne transmission, with this idea that when you're close to somebody who's coughing, you can both have particles deposit onto your facial mucous membranes and be inhaled. This has a specific meaning for healthcare workers because it says that just because somebody's coughing at you, the face mask will only protect you from the things that are projected onto the face. And so, and anything that's small enough to be inhaled and deposit in the lower parts of the respiratory tract just go around the edge of those loose-fitting surgical masks. And this is what motivates recommendations for healthcare workers to wear respiratory protection for viral respiratory diseases. These are just some images from our paper from 2015 that talk about aerosol disease transmission and try to illustrate this. So here we have the event that person A is coughing and person B is able to inhale particles. Then the dots of different colors or different sizes representing vaguely the polydispersed aerosol from a cough. And so these particles clearly can project and deposit onto the facial mucous membranes of person B. Person B can also inhale these and inspire these aerosol particles. Now, over time, we get dispersion in the room that depends upon particle size, ventilation and airflow, various other parameters, but you see that there's some size selective separation, and yet still person C is far enough away that they're not getting any exposure. Whereas ultimately over time, person C has the opportunity to inhale the smaller cough particles that remain suspended in air while the larger particles have deposited. Now, how to measure how healthcare workers are exposed to viruses? There's many different technologies that have been used in the literature to measure viral exposures. Over here on the right, starting from the top left, is the NIOSH two-stage bioair sampling device, which collects particles into 2 tubes and to a filter. So there's 3 different size selection processes. Next to that one to the right is an image of an Anderson impactor. Below that is a button sampler. The bottom there is what's called a Burkhardt cyclone, which is a very high volume air sampler. Most people are probably familiar with the SKC biosampler, and of course your standard filter cassette. For viruses, people typically use PTFE filters for these because they're pretty smooth, so it's easier to extract. When choosing a sampling device, though, there's a lot of different factors to consider, which is why people have used a lot of different instruments. So one of the first factors to consider is, are you planning to identify your virus or quantify your virus using culture-based methods or culture-independent methods like PCR or other genomic sequencing techniques? And if one is planning to use culture-based methods, it's important to try to minimize the damage to the virus during sample collection. And so that prompts people to use things like impingers, where you're sampling the virus into a fluid, and so it's less likely to be desiccated and destroyed, such as might happen if you are sampling it onto a filter and the continued airflow is like dehydrating that. People will also use the Anderson impactors for that because you can sample things into media. For PCR methods, there's a wider variety of tools available because you're not worried about virus destruction in the same way. And then your trick is just making sure that you have an efficient extraction of the genetic material from the sampling medium. One of the nice things about the NIOSH samplers is that, for example, the tubes can then be readily analyzed in the laboratory and don't require additional processing to extract genetic material from those sample collection devices. The next question is kind of what is the necessary sensitivity of your sampling method? And so this is really where you're trying to manage the trade-off between having a sampling flow rate and the sample duration for the task to collect enough material for the task that you want to sample, and whether or not you need to have size selection. So for example, in the NIOSH sampler, your volume of air is now divided into 3 different pockets, which would decrease the potential sensitivity of your sampling method. You know, high flow rate sampling devices are nice, but they tend to be bulky instruments, and so you can't necessarily use those for personal sampling devices. And for healthcare tasks, when we've done sampling, those tasks tend to be a 5 to 15 minute duration. So like, you know, if a healthcare worker goes into a patient room to perform a care activity, that's a relatively short sampling duration. And so if you're operating your sampling device at 2 to 3 liters per minute, you know, you're running into a sensitivity issue. And I'll show results to that effect later. You also have to decide if you want to use personal or stationary samplers. Not all of the samplers are very wearable, and some stationary samplers in particular can be operated at very high volume, which can help boost your sensitivity to detect the organisms. But for example, you know, the logistics of wearing an SKC biosampler or pinned to the lapel are incredibly challenging. And there are personal Anderson impactors that you could use, but those are not common. We also have to decide, do we have a value for size selective sampling? So size selective sampling for influenza, for example, has been a priority in the past because we're uncertain about what is actually the transmission route, and characterizing the virus in the respirable range is important to understand whether or not inhalation is an important transmission route for influenza. If your goal is simply to know that things are there and that present, then size selective sampling may not necessarily be of value to you. Now, there's not a whole lot of information about how all of these samplers perform for viruses. And I've shown a couple of results here that are trying to demonstrate kind of equivalency between instruments, but there haven't been very many studies that talk about specifically the efficiency of the instruments. So it's difficult to make comparisons between instruments because we don't know how well each of them performs. And certainly, you know, the extraction procedures that are used for all of the samples to do the PCR analysis can vary a little bit between laboratories. And so there's a lot of challenges with comparing information across studies. And again, sometimes the higher sampling flow rate devices are cumbersome to use, but they can be used and have been used for exposures to viruses. Now, when we go to start thinking about how to measure exposures to surfaces, again, we have to decide if we want to use culture or PCR methods. And here, one of the issues is the destruction of the sampling device. So for example, when we were preparing to do our hospital studies, we had proposed to our PCR laboratory technicians that we use the cellulose sponge, which is shown here in the bottom left, because that's what we were using in some laboratory studies with fluorescent tracer. But the cellulose sponge breaks up when you beat it to extract the genetic material and creates fragments that were a concern that might interfere with the PCR analyses. So on the top left is called a macrofoam swab. This specifically is an Enviromax swab. It's about the size of a small tampon is the size of the foam piece here. And on the right is a Copan swab, which is basically like a large Q-tip. So these are 3 of the common swabs that are utilized. The Enviromax foam swab on the left is what is used by the CDC for their norovirus sampling, such as the work on cruise ships. But the Copan swabs are popular in healthcare studies because they tend to just be around healthcare settings because they're used for other medical purposes. And they work fine, except that they're very small. So you can't necessarily sample a large surface area with these devices. And so there are also a variety of wipes that have been used for virus sampling. And again, wipes have the advantage that you can cover a larger surface areas, and it's clear that the efficiency of some of these swabs depend upon the surface area that they sample. Again, there's more data about the performance of swabs for sampling enteric viruses on surfaces. On the left is an example from a study by GNU Park with the CDC and their Enviromax foam swab. That's the macrofoam swab. And here they're comparing 4 different swabs, a cotton, a rayon, a polyester swab, and sampling 4 different surface areas. And the y-axis here is the viral RNA recovery. And you'll see that even the highest bars for the macrofoam swab, which is the one on the farthest right of each grouping, is still less than 30% recovery of viral RNA, but it is by far better than 3 other sampling devices, but also that the viral recovery decreases with a larger surface area samples. And this study was a laboratory-based study using stainless steel surfaces and the G2.4 norovirus. There's been some reviews of the literature about this, and it is in general, I would just say that the sampling efficiency results are kind of all over the place. Some studies show that efficiency depends on the virus concentration. Some studies show efficiency, or most studies show that efficiency differs by surface type. So the more textured your surface is, the lower efficiency you're going to have. There's also generally that the more dry the material is, the lower the sampling efficiency that you have. So studies that put down a wet virus suspension onto a surface and sample immediately will tend to collect more material than if the virus suspension is allowed to dry for 30 to 60 minutes and then they are sampled. There's some influence of the sampling type, as we can see in the figure on the left, and there's limited evidence that there's difference between the viruses. That has not been fully explored to know if it's really specific at the strain level, or it's more like it's an envelope versus an unenveloped, or somehow depends upon the shapes. Overall, the detection limits seem to be on the order of 10 to the 3 or 10 to the 4 gene copies, and the sampling efficiencies vary widely, but are most frequently below 50%. So Turnage and Gibson have a review of papers that were published as of 2017. And again, most of these studies are performed with enteric viruses, not respiratory viruses. And with respect to desiccation time, I will note that many of the sampling devices, the swabs and the wipes, can be purchased dried or pre-moistened. And most people purchase the pre-moistened ones. In our experience in the lab, we were testing some dried sampling devices and dried macrofoam sampling devices. And the issue was, is if you have a little pool of water, the kind of surface tension on the dried foam means that it just kind of is next to the water, and then suddenly it'll finally break that tension and all be sucked up. And I think to help compensate for this issue of desiccation, people tend to use the pre-moistened. Especially if you're using culture, you can get the swabs that are pre-moistened with like a protein buffer to help enhance viral growth or culture later. On healthcare workers, there have been some studies to directly measure viruses, and I'll show you our results in a minute. There's a couple methods that are used. One is kind of elution methods, and the glove juice method is commonly used to study healthcare workers' hand contamination, especially for multi-drug resistant bacterial organisms. And in the glove juice method, you basically take the healthcare worker's hand and you put it in a bag or a glove that's filled with some kind of buffer, and then you massage the hand to elute the virus or bacteria off the hand into the liquid. And then you can analyze the liquid for your organism of interest. And healthcare workers generally will agree to do this. They don't find this particularly invasive. And the citations here are from some studies by Lisa Casanova at Georgia State University, who uses elution methods in her studies about self-contamination during PPE doffing. She's also demonstrated that you can take, whole pieces of personal protective equipment and recover virus from that. But again, she's doing this in the context of simulation studies, mostly using a bacteriophage. You can also do swabs or wipes on healthcare workers, and I'll show some results later of our swabs with healthcare workers. We find that healthcare workers are fairly willing to have their hands swabbed or wiped, but they are not as receptive to having their faces swabbed or wiped. So as I've talked about that measurement methods, I think there's some gaps that are very clear. That we have limited data about the efficiency of many of our sampling methods, which makes it difficult to compare across studies at a highly quantitative level. I think qualitatively we get a sense, and so studies show that there's a lot of variability in general, and so it's hard to compare directly. But certainly comparing within studies to look at relative magnitudes is robust in this context. It's not always clear how to interpret environmental measurements for the actual dose to the healthcare workers, because what's on the surface or what's on their hands, it doesn't necessarily relate directly to how much virus gets to the actual place in the body where infection is initiated. And we've to date really relied on exposure modeling that considers human behavior to describe the transport from the environment into the body sites where infection occurs. So I'm going to talk now a little bit about some work that we did, my research team did when I was at the University of Illinois at Chicago. It was funded by the Centers for Disease Control Prevention Epicenter programs. And we're going to talk a little bit about the aspect of our study. It was specifically about measuring virus exposures to healthcare workers in the hospital. And overall, I say that we demonstrated that yes, healthcare workers are really exposed to viruses, and that while not every sample is going to be positive, they're going to be positive frequently enough that given the limitations in the methodology of the sample collection, it's pretty safe to assume that viruses are present in the air and on surfaces around infectious patients. And so the part of this study that I'm going to talk about involved observing about 3 hours of patient care in the morning when all of the activity is going on in the hospital for 58 patients. We sampled for the virus with which the patient had been diagnosed within the last 3 days. So we weren't just looking for any viruses, we were looking for the specific virus associated with your patient. In addition to sampling for virus, we observed a bunch of information about time activity patterns and PPE use. And I want to point out a lot of my research team here from my former students at Chicago. Going from right to left is Yumin Su. He has graduated and is now working in the semiconductor industry in Taiwan as a health and safety professional. Yua Edemwande was an undergraduate working with us. She's now working on completing her Master's of Public Health and Epidemiology. Lynn Fan finished her PhD and is now a research safety specialist at Stanford University. And Rachael Weber completed her master's degree and now is an infection preventionist at Northwestern Memorial Hospital. So I'm really proud and want to acknowledge their important contributions to this work. In particular, a lot of what I'm showing is part of Lynn's PhD research. So in our study, like I said, we ended up observing 58 patients. It took us a year and a half to do that, not continuously because we were working mostly during infectious seasons. Of our patients, the majority of them had influenza A or influenza B, followed by rhinovirus. Then we had 1 or 2 patients with respiratory syncytial virus or parainfluenza. This is just some qualitative information about how frequently we found different viruses on different surfaces. And I will say all of these patients were hospitalized at the University of Illinois Hospital in Chicago. They were in a variety of different patient settings. And when we reviewed their medical records, they were not highly ill. So there was nothing particularly severe about their infections or comorbidities or anything like that. Some of the patients were quite mobile when we were in the room, others were entirely bedridden. but none of them were really severely ill. So these are some of the surfaces that we sampled. We sampled before some surfaces at the beginning of the observation period, and again at the end of the observation period, and some were sampled just at the end of the observation. So this is one sample for each patient at a maximum. And so you see that not every surface is always contaminated, but things are frequently contaminated. So the keyboard is on the computer workstation that is assigned to the room, is permanently in the patient room, not the mobile computer station. Some wards had mobile computer stations. The call button is for the patients to call the medical staff, and the bed rail. And so you see that there is some variety, but things are fairly frequently contaminated. Quantitatively, these results show quite high variability. So note this is a log scale on the y-axis of gene copies per square centimeter. And there's not statistically significant or obviously pattern differences between the amount of contamination on the different surfaces, but the concentration of virus gene copies on these surfaces varies by several orders of magnitude. We did air sampling in two ways. We placed stationary air samplers in the patient rooms within about a meter and a half of the head of the patient's bed. They sampled for about 2.5 hours. And we had a total of 47 stationary samples. We then also tried to recruit at least one healthcare worker per day to wear a personal air sampling device while they were providing patient care. It was difficult. Not everybody wanted to wear that, and so you'll see we don't have quite as many samples for that. Those samples, as I said, are relatively short duration, about 10 minutes. Overall, the stationary samplers were positive 43% of the time. We were using the NIOSH biosampler, which, as I said, has 3 different size fractions. And so the pattern amongst the different size fractions was not consistent on all of the different sampling times. Every time we sampled, it wasn't that one stage was positive. It was a mix of stages in the sampling device that were positive. The other thing to note is that the mean concentrations here, shown here are about 10 to the 3 gene copies per cubic meter, but it went up as high as 10 to the 5th gene copies per cubic meter. For the personal air samples, only 22% were positive in any stage, and none of them were positive for the 3rd stage, which is the larger viral particles. But given the low numbers of samples, it's difficult to interpret. Here, and I don't know why that's 6. I think it should be 5 of positive. One thing to note, though, is that the virus concentrations in the personal air samples were relatively high compared to the stationary air samples, which makes sense because the healthcare workers generally were close to the patient. But they were on the order of 10 to the 6 or 10 to the 7 when they were positive. So this is a mean of the positive samples, not a mean of all of the samples. But this is important because it suggests that healthcare workers will have moments where they have a high potential exposures. And this is not really surprising. It's also consistent with some work that we did to look at aerosols emitted during bronchoscopies, where we get very periodic, very high concentrations, which show short duration, extremely high risk potential. Given the low infectivity of many of these, or the high infectivity of many of these viruses, it's important that we anticipate and control these short duration, high exposures. We did do some work to try to identify potential determinants of virus in the environment, and this shows some correlation between contact patterns of healthcare workers and virus concentrations. But nothing really stood out, and part of this I think was just a limitation in terms of sample size, and the fact that there was variability in the virus concentrations, but not so much variability in some of the other things. Notably, positive stationary samples were associated with the event that more than 5 healthcare worker encounters occurred with the patient during that 3-hour window, which may reflect that there's more activity in the patient room, increasing aerosol concentrations, or it could be that these patients were just more sick. We also tried to get healthcare workers to let us sample on their bodies and personal protective equipment, and these were done using those little Copan swabs. And so we found virus on gloves, gowns, masks, personal stethoscopes. We also found them on bare hands. This was before hand hygiene, on the face and on the scrubs that were worn under the gowns. The concentrations you'll notice here are much lower than what we saw on environmental surfaces, except that there were kind of extreme values here. And this should be copies per centimeter squared, not per cubic meter. But this does confirm, and we believe it's the first study to confirm, that viruses are on healthcare workers after they provide care to patients. Now, we did not measure healthcare workers as they were going into the room, so some of this contamination could be residual from previous patient care activities, but it does confirm that the virus of the patient, so again, we were just measuring the virus that the patient was sick with, is on healthcare workers. We also were looking at surface contacts, which showed some interesting patterns by, by job. So on the left is the total number of times people touched the surface in green here. And again, you'll see providers, which would be nurse practitioners and physicians, contacting the environment much less often than other jobs. And again, here, self-contacts were much lower amongst nurses and nurse technicians than they were among other job titles. That means that those healthcare workers touch their own body less frequently than others. So we were looking at how people touch their bodies during care, and this was kind of the frequency with which healthcare workers touch their own body during a patient care activity. And you'll see they are frequently touching their personal protective equipment, which is a potential for self-contamination. So surface is, I think our work and the work of others show that this is ubiquitous, and that there's concern for short-term high-risk exposures for healthcare workers for inhalation. Now, unfortunately in healthcare, there's a strong reliance on personal protective equipment rather than looking at a lot of engineering controls. And so we had a paper that came out last month in the American Journal of Infection Control that is trying to argue that we should use a systematic risk-based approach, which is not a novel approach at all to selecting PPE in the industrial hygiene realm, but has not been adopted in the healthcare setting. And this would be what we described as starting out with a job hazard analysis, where you're looking at what are the infectious body fluids present, how are they contacted, infectious disease hazards, going through a selection where you're trying to document and make your decision-making transparent to build trust with healthcare workers and align the hazard analysis with the infectious disease hazards, as well as undergoing a robust evaluation of PPE, where you're not only looking at donning and doffing, but usability in general and whether or not it's fit for purpose. And this came out of our experience interviewing people in their Ebola preparations, and how every hospital we talked to was doing their own trial and error approach and trying to figure out how best to protect their own healthcare workers. But we wanted to describe this more formally. We'd like to move this forward and see if we can develop a guidance document and test with users. So if anyone is interested in participating in such an activity, please get in contact with me. So now to coronavirus. Today, it was announced that it's now called COVID 2019 instead of novel coronavirus 2019. You probably all are aware we have more than 40,000 cases today in China and more than 1,000 deaths. While the initial cases were linked to a specific seafood market, the actual host at the seafood market that was the source is unknown. The genetic sequence indicates that the virus is originally has a natural reservoir in bats, but they don't know yet what the mediating animal is. At this point, there is a PCR-based diagnostic test available. And one of the important things for healthcare workers is that the receptor binding domain for the new virus is similar to that in SARS-CoV, in that it looks like it uses the ACE2 receptor, which is located in the lower respiratory tract, indicating that inhalation and deposition of the virus in the lower respiratory tract poses a risk of infection to healthcare workers. Descriptions of case series from China indicate that the initial symptoms are fever and coughing with shortness in breath. Among hospitalized patients, at least, pneumonia is extremely common, with more than 70% of cases in the reported case series presenting with pneumonia. Fatality seems to follow bilateral pneumonia with multiple organ failure. There has been some reports of atypical presentation with abdominal pain, and it has been confirmed that, at least among patients with abdominal pain, that the virus is, and diarrhea, that the virus can be found in stool. The initial case reports from China show increased severity among elderly men with comorbidities, but that may just be a feature of the specific cases that they're reporting. At this point, the CDC is indicating that they believe the incubation period is anywhere from 12 to 14 days, which I think means that they don't really know. And the presumed transmission route is similar to SARS and MERS, which is described as respiratory droplets. Epidemic modeling from the case reporting in China suggests that the basic reproductive number is about 2.5, which means that there it's continuing to grow. There's not an indication yet that the epidemic is controlled, that we're going to start seeing a reduction in the number of new cases. The model by Wu et al. In particular predicts emerging outbreaks in many of the major cities in China, and one is now being seen in Beijing. In the US, so as of the January 17th, the CDC had increased screening at airports, but they have only identified a few cases for testing at the airports. The US does manage 18 quarantine facilities at ports of entry, and some of these and quarantine facilities at military bases are being used for the flights of people that were brought by the US government out of Wuhan. They activated their emergency operations center and have released a PCR diagnostic test. On the 31st, there was a presidential proclamation that limited entry to the US of persons who've traveled to mainland China to citizens and permanent residents. And this is something that has not been done for a long time. It's very striking. So the CDC, in their recent reports as of Friday and morbidity and mortality weekly reports, indicate that this was done in part to help the public health system and hospitals in the US prepare for in case that there is a surge of cases in the United States. As of the 4th of February, the CDC reported that there are 293 persons under investigation for coronavirus in the United States and 11 diagnosed cases, 9 of whom had traveled to Wuhan, 2 cases among close contacts. The CDC apparently has received inquiries regarding 650 persons. Of those, they recommended testing for just under 300, and about 210 have been tested. And most of these patients were identified through healthcare settings. That includes emergency departments at hospitals, outpatient clinics, as well as, interestingly enough, student health clinics, which is a new area that I hadn't seen receive a lot of attention in terms of preparations for public health control. So these are the CDC recommendations, and the CDC, I think, stepped up a little bit this time compared to some of the recommendations for other outbreaks. So on the left are some recommendations for in healthcare facilities. In particular, patients are supposed to be isolated and to wear a mask unless they are put in an airborne infection isolation room, at which point they can remove their masks. Aerosol generating procedures are supposed to be, you're supposed to limit the number of people present and do culture only in BSL-3 facilities. This time, the CDC has recommended respirator use, so they have droplet and airborne precautions. So they recommend hand hygiene, gloves, gowns, respirators, and eye protection. And they specifically note that these things should be used consistent with OSHA regulations. This is a change from recommendations in previous outbreaks that they have stepped up immediately to say respirators and eye protection should be used for all patient contacts, not just for aerosol generating procedures. They also specify healthcare workers must be educated, trained, and practiced with the PPE. And while most healthcare facilities would do this based on their own personal experience, it's a great recommendation from the CDC this time. And to work with public health authorities to monitor healthcare workers and to use non-punitive sick leave policy so that healthcare workers who are exposed or develop symptoms are not penalized as a result in terms of lost income or lost jobs. A last note here is that there's a review that came out, a rapid review that came out in 2020, not 2010. It came out last Friday, looking at SARS and MERS and other human coronavirus in terms of surface persistence and cleaning effectiveness. This review concluded that it's likely that, like other human infectious coronaviruses, the persistence on the surface would be up to 9 days. Depends a little bit on temperature and humidity. Coronaviruses in animals have been shown that infect animals routinely have been shown to persist longer, but the other ones that infect humans have lower persistence. The efficacy studies for cleaning show that ethanol greater than 70%, or 2-propanol greater than 70%, or hydrogen peroxide greater than 0.5%, or sodium hypochlorite greater than, the only value tested was 0.21%, given a 1-minute contact time will yield a 3 log 10 reduction. So it's not a full elimination, but it's a substantial reduction. They do have some other cleaning materials that are also effective at this level, but require longer contact times. So thank you, and we'll be making some materials available. So I'm happy to take some questions at this time.
Wonderful. Thank you so much for that excellent presentation. At this time, we are opening it up to questions and answers. So please feel free to use that Q&A bar in your Zoom window to ask any questions to Dr. Jones. We do have another question that has come in already. Someone was wondering how you protected the researchers during your study.
Yeah, so during our study, we asked our research team to wear the same personal protective equipment that was required for the healthcare workers at a minimum. And though none of our patients that we were studying were under airborne precautions, we made available to our research team N95 respirators, as well as powered air purifying respirators for them to use as they chose. But normally they would wear a gown, gloves, a mask with a face shield, and or a respirator.
Wonderful, thank you. Again, you can enter your questions into the online webinar chat and also the Q&A bar. Someone did have a question regarding which one the CDC uses. That person could please be more specific as to which part of the webinar you're referring to. That would be wonderful. We do have another question. Given 2 to 14-day incubation periods, is the transmission period earlier than 2 days?
I think that question is asking kind of when do people become infectious, and it's not clear. There is some discussion in the published studies and the CDC documentation that people may be infectious before they're symptomatic, but I think at this point, because most of the cases are in China and it sounds like it's a very chaotic situation there, we don't have robust data about when people become infectious over that pathway or over that incubation period.
Thank you. Another question, are they doing air sampling for coronavirus to determine if it's truly airborne versus droplet transmission?
I personally do not know if they are doing any sampling for that.
Thank you. Another question about hand sanitizers. How effective are hand sanitizers with 70% ethanol, considering contact time of 1 minute is needed to significantly reduce many viruses?
So I personally don't know the database answer for that, but I would say that people generally don't use the hand sanitizer for 1 minute. The evaporation time for that hand sanitizer is much quicker than that. So I would say that it would probably remove some virus from the hands, but not enough. I'm not sure if you're aware, but the FDA recently has asked some of the manufacturers, in particular Gojo, of the hand sanitizer products to change their advertising about these products preventing things like flu and Ebola, because it is clear that they do kill some of those viruses, but it's not clear, as I was mentioning before, about how much virus on a hand translates to infection risk. So I think that they do kill some viruses and they would kill some coronaviruses, but I'm not sure that they would obtain the same efficacy for coronavirus as using soap and water.
Great, thank you. We have another question. They said that they have a supply of PPE from SARS response that they're looking at deploying for COVID-19. Do you know if expired PPE, including surgical masks, are still any good?
So there, I'm hard to answer this one. I mean, there's nothing fundamentally about a surgical mask that degrades over time, but I can't in good faith recommend that you use a product that's expired.
Great, thank you. Let's see, we're having a lot of questions about the coronavirus, very timely presentation. So I'm just working through these here. So thank you everyone for your questions. Someone was wondering how effective that virus can be transmitted through building ventilation systems.
So I don't know. Now there is a news report that came out last night of potential transmission within a building in Hong Kong, although the transmission pathway is more hypothesized around plumbing pipes than ventilation systems. And I think at this point, we don't know how long the virus would survive in air, but to know if we're looking at concerns about transmitting over long distances through ventilation. But that was a concern with SARS. And I think that that's something that is a potential. At this point, we just don't have all that much information about this specific coronavirus. But if we recall back to the SARS outbreak, I mean, there was clearly transmission between apartment buildings through the air, as well as through sewer pipes or venting of sewer pipes within an apartment complex. And that virus was also found in stool, like the current coronavirus is. So I think it's something that we need to be aware of, but I don't know that we've gotten to the point of having to panic about that, at least in the United States yet.
Great, thank you. We also had an attendee who wanted to add a comment about PPE and the N95 masks. They noted that the elastic can also get brittle and break more easily.
Yeah, with respect to the expiration date. Yeah, same thing with gloves and some of the other gown materials, that over time the materials can degrade so that they offer less protection or are more fragile to use than initially, which is why the expiration dates are there in particular.
Great. And it looks like someone also added that NIOSH will soon be putting out some guidance about expired N95s as well. So you can keep your eyes open for that NIOSH guidance.
Yeah, and the National Personal Protective Technology Laboratory had a webinar this morning about healthcare and N95 storage, stockpiling, and kind of efficiency of use. Unfortunately, I missed that, but I assume that they're working very diligently on that issue and would be a great resource going forward.
Great, thank you. We also have another question about air sampling. Are air sampling devices installed to collect samples in hospitals where the 2019 coronavirus has been reported in the USA? Are you aware about that?
I am not aware.
Okay. Um, we have plenty more questions, so thank you everyone online. I'm doing my best to get to all of these. Are you familiar with any studies examining exposures to viruses related to surgical smoke plumes?
Not specifically viruses. I know that there have been case reports of, for example, papilloma or herpes infections among people who are doing like laser hair removal and some of those procedures. And I feel like I've seen a study that attempted to measure that viruses. So if the person wants to follow up with me afterwards, I can point them to that. But I don't think there's a big body of literature on that. I know that there's ongoing work looking at exposures to general particulates associated with surgical lasers and laser hair removal, including some by my colleagues and one of our students here at the University of Utah. But I'm just feeling like I've seen an article from maybe 7 to 10 years ago that had some data about that.
Great, thank you. We have another question regarding if hospitals have varying requirements regarding disinfection procedures for rooms.
Yes, in general, they do have they can have different procedures for disinfection requirements, and different products that are used and different tools that are used, and that varies between hospitals. So there are some general guidance, but there's no specific policies that come out from CDC and HICPAC about when you need to clean a room, how often you need to clean a room, and what tools or products. So the EPA tests doesn't test, but certifies certain disinfectants. Not all of those disinfectants, however, are tested against all of the organisms that are of interest in healthcare settings. And in particular, a lot of them are not tested very, very competently or very much against viruses. So some of my colleagues at Clemson University have been working on a study testing disinfectant products against norovirus and getting some slightly different results than we expect, but those are very preliminary. And so it's up to the individual hospitals to set the policies and procedures for their cleaning. That's in general, but also for something like an epidemic.
Great, thank you. And to continue on with that question, someone also was wondering how ventilation systems specifically might be disinfected.
Oh my goodness. I have no idea.
It's a great question.
So ventilation systems are super complicated, and this is an issue that they've struggled with Legionnaire's disease for many years as well, is how do you get a complicated system that's hidden behind walls and in ceilings clean? And I would say that probably the only things that would be feasible, because you can manually clean them, would be some kind of gaseous disinfectant or potentially a UV source that could distribute through the ventilation systems. But that's beyond my, I can't say that I've seen evidence that those things have been used or that they work.
Great, thank you. And we are coming towards the end of our time here, but if you do have another question, Dr. Jones has provided her email address right up there on the screen, so you're welcome to follow up with her for the slides and other reference articles. I would like to again thank you to everyone who joined us for today's webinar, and a special thank you to Dr. Jones. The NIOSH Education and Research Center Industrial Hygiene webinar series is taking place the second Tuesday of every month. This new series is in addition to our NIOSH ERC Ergonomics webinar series, which takes place the third Wednesday of every month. Be sure to check back to our website for more information and to register for upcoming events. And you can do that at coeh.berkeley.edu. And there is a specific page dedicated to all of the NIOSH ERC webinars. Thank you all so much for your wonderful questions and participation, and I hope you have a wonderful day. Thank you, Dr. Jones.
Thank you.